So let's go over some brain abnormalities that are associated with schizophrenia. Uh, what I did here was I basically took what the book was going over, and then I have another video added onto here that's extra if you wanted some more detail, because some of the stuff that they have now has been left out. But here you go. Most people with schizophrenia have less gray matter and white matter. They have larger than average ventricles, and I have a nice picture for you on that one. They have minor abnormalities in subcortical areas, which was the smaller hippocampus. Dang, that hippocampus seems to be causing problems in all of these. Um, there's deficits in memory and attention consistent with damage to the frontal cortex. And then we have another one here. So there's also lateralization differences in people with schizophrenia. So when we learned about normal right-handers, then we know that the left planum temporale was usually slightly larger in most people. But you find in schizophrenics that their right planum temporale is slightly larger. And as you know, a hallmark of schizophrenia is hearing things, auditory hallucinations. And we also know that the right hemisphere tends to be more negative emotions. So it kind of is interesting that the area where there would be kind of hearing voices, that area of the brain is right there, the right planum temporale. So it kind of makes sense that that area would be larger. They have lower than normal activity in the left hemisphere. So we also know that lower than normal activity in left hemisphere is associated with more depression, and they're more likely to be left-handed. Um, Here's a picture of some larger ventricles here. So as you can see, these are the normal size ventricles, and these are in identical twins. And I took this from your textbook, whereas these are from the schizophrenic twin. So now what we're going to do is we're going to go on to some different chemical hypotheses of schizophrenia. So I want to make this simple for you because I know it's, getting to the end of the semester and you're tired. Basically, one theory is that there's an excess activity at the dopamine synapses. And then the other theory, which we're going to go over on the next slide, is that there's too little activity at the glutamate synapses. So the evidence for this is sometimes you get the substance-induced psychotic disorder, like on methamphetamine, and it results on you get this very similar symptoms to schizophrenia: hallucinations, delusions resulting from large doses of amphetamines, methamphetamines, or cocaine. And so each one of these drugs, they prolong the activity of dopamine synapses. So we're seeing the same behaviors as what you see in schizophrenia, which is giving us this thought of, maybe it's excess activity at the dopamine synapses. So research indicates it's specifically at these D2 receptors. And when we look at the medication, there was older medication that caused a serious complication that we'll go over, the tardive dyskinesia. But now the newer medications focus more on these D2 receptors, and there's less side effects from the newer medications. Okay, here's a picture again from your textbook, and the PET scan of a patient with schizophrenia. The PET scans of the patient with schizophrenia taking clozapine versus a period off the drug. So this is off the drug, and this is on the drug. Okay, and so this is showing that there's more activity when they're on the drug. Now, some of you say, well, what? More activity? Well, wouldn't that make them crazier? But actually, what the frontal lobe's job is and what the cortex job is a lot of times is to kind of inhibit neurons from firing. So if these neurons here are not firing indicated by this, then you have a lot of activity and it's like massive chaos. So if you can imagine, like, in order for you to learn, you probably need a quiet, focused area where you can specifically focus in. But what if you were listening to this video and there was all kinds of other teachers talking over me, talking over me? It would make things very chaotic. So let's contrast this with the glutamate hypothesis of schizophrenia. So an alternative is kind of glutamate serves to kind of block the activity of dopamine. So if you don't have enough glutamate, then it won't inhibit the dopamine activity. So it could be the excess dopamine activity, or it could be low levels of glutamate activity that inhibit it. And they talk in the textbook about PCP, and that PCP works on glutamate, and that you see a lot of the same symptoms of people on PCP with schizophrenia. Some of the more negative symptoms, like lack of affect and differentiated walking, those similar things like that. So you've got the amphetamines and cocaine that seem to be more like the positive symptoms, and then when you take PCP is similar to some of the effects on PCP are similar to some of the negative symptoms. So they're using both of these theories, an excess of dopamine activity or maybe less activity of glutamate, to kind of explain at the chemical level schizophrenia. So with this knowledge of the chemicals, then what we can do is we can come up with treatments. So since we know dopamine, glutamate, the treatments would work on these neurotransmitters. So thorazine is a classic drug for treating schizophrenia, and it relieves the positive symptoms of most patients. So most of them, they relieve schizophrenia, and they work by blocking dopamine. So you've got chlorprazmine and Haldol, or another two types of antipsychotic drugs, and they both work by blocking the dopamine synapses. So basically, an overview is most of the antipsychotic drugs are working by blocking the dopamine activity. But a problem with these early ones is they created this pretty bad side effect called tardive dyskinesia, and it's a motor disorder that once it starts, they couldn't get rid of it, because we know that there's dopamine receptors in the mesolimbocortical system, okay? But there's also some for the movement system, which would be the mesostriatal system. So the tardive dyskinesias, they have involuntary movements, like their arm keeps moving up and down, or and they can't stop it, or their tongue keeps moving around and around and they can't stop it, or they had serious tremors. So as you
in Virginia, and I have tardive dyskinesia. My journey began the last year in high school. I made a suicide attempt when I was 17 years old. You know, I didn't really have words for what I was feeling then. I didn't know anything about depression. I had no idea that it could ever get any better. I was in the hospital for 30 days, and I was diagnosed at that time with major depression instead of bipolar disorder, which is my diagnosis now. I've been on so many different medications over the course of the last 25 years now, 26 years, and nothing's really seemed to work long term. When I started having the movements, I had no clue whatsoever. Other people would notice them and ask me, why are you nervous, or why are you fidgeting so much? I'm like, what do you mean? You know, I'm just sitting here, or I'm just standing here, not doing anything. So I had no idea what they were seeing.
I noticed that Raven was having some movements, and they were very unusual. And he didn't seem to notice himself.
When my mom first noticed it, she would be like, stop fidgeting. Or she'd just walk over and like place her hand on my leg to keep it from, to remind me to keep it from moving, which was really frustrating, because I'm like, you know, I didn't realize what was happening, and I'm like, well, I can't stop it from moving, and I didn't know why.
Long-term use of antipsychotic medications entails a difficult trade-off between the risk of tardive dyskinesia or the benefits of alleviating psychotic symptoms. Dr. Henry Nasrallah is a renowned neuropsychiatrist, educator, and researcher with expertise in schizophrenia and related disorders. He explains TD for us.
And we refer to it as TD for short, is this late onset movement disorder that affects multiple parts of the body, but most frequently the face. So it is facial expression and grimacing and eye blinking and mouth moving and tongue darting in and out and continuously moving. It is very attention provoking for people looking at the patient because they look like they are really inappropriately moving their face, and that can be extremely embarrassing for the patient. This side effect, tardive dyskinesia, is potentially irreversible in most cases, and it is a consequence of long-term treatment with antipsychotics. Sometimes not even that long. Sometimes a few months can produce it in some patients who are at risk. The most prominent scientific explanations for TD is what we call dopamine receptor supersensitivity. Now, dopamine is a neurotransmitter in the brain which is involved in schizophrenia. Every single antipsychotic ever discovered blocks dopamine receptors. Turns out that if you block dopamine receptors for a long time, the brain reacts, and it reacts by manufacturing more dopamine receptors. So now patients who are taking antipsychotics that are blocking the dopamine receptors that were overactive in the first place, with time they start making more dopamine receptors, and that's what we call supersensitivity. There are certain groups that are more at risk than others. Example of that would be women more than men, African American more than Caucasians, people who are taking high doses compared to those who are taking low doses, and people who are taking medications not for schizophrenia, not for psychiatric condition, but there are medications that block dopamine receptors the same way that antipsychotics do, and it's used in internal medicine for gastrointestinal abnormalities like nausea, vomiting, and gastroparesis. Many of them would avoid going out because of embarrassment, because their face is moving all the time and people looking at them all the time. It's so unfair to the patient.
Schizophrenia. So they came up with these new second generation antipsychotics, and what they do is they work more on different types of receptors. Um, so they have less movement problems. Um, so they found that certain drugs are working specifically on the D2 receptors, but then there's others that seem to antagonize these serotonin type receptors. So the second generation antipsychotics seem to be working a little bit different, and they were developed in order to stop the tardive dyskinesia. Some side effects of these second generation antipsychotics are weight gain and immune system impairment. They don't seem to increase the quality of life anymore of the older drugs, but they don't have those same movement side effects, so they're going to go with those rather than the earlier ones. Final summary of schizophrenia is it can't be explained by a single gene or a single neurotransmitter.